up to be, have some of that workup done before they get to GI, because I think patients get frustrated when they get there and they're like, oh, I have to go through all this stuff and then get answers. So it can be frustrating for people. So first, I just kind of wanted to go through colon cancer screening, which I think is obviously something that we deal with all the time, right? We're primary care, we're trying to do preventative care. So this just talks about kind of the leading sites of new cancer cases and deaths. And this was actually from last year, so it's updated. So colon and rectum cancer, they actually don't differentiate them, I think, because a lot of the death certificates don't specify that it's rectal versus colon. So they kind of group them together, but it's the third leading cause of new cancer cases, as well as cancer deaths in both males and females in 2022. So looking at kind of the states in general for colorectal cancer screening use, actually it's all of them. So it's not just colonoscopy or Cologuard or FIT testing. They kind of group them all together, but talks about kind of percentage of the states and how well we're doing with screening. So Maine's actually doing pretty well. We're 75% that they say. This is from 2018, so it is a little bit older, but where I think the only state beating us is Massachusetts at 76%, which I don't think any of us are shocked about. But we're doing a pretty good job, but we're still missing
recording in progress
the amount of people. So kind of colon cancer screening recommendations, they did, I'm sure you guys have talked about kind of like the new screening update where they've lowered the age. So there's a lot of evidence for screening 50 to 75 people at average risk. There's not a ton of evidence for 45 to 50 at average risk, but they are recommending that now. And then just kind of talking about like, when do we stop screening? So after the age of 75, I think it's, beneficial to have that discussion with patients. Like, is this something you even want to think about? Do they have a lot of comorbidities? Do they have lung disease, heart disease? Do we really want to keep screening them? I will say that I've had patients that are like 90 that get referred for a colonoscopy. And it's like, do we really want to do this? I've had some GIs will do it if they're super healthy. They don't have any comorbidities. They're still walking active, but most of them don't want to do it after the age of 85 because of that. And I think that's, pretty reasonable. Also, as far as kind of first line screening tests, they do still recommend colonoscopy. They kind of push that. And I will say in the GI practices, that's primarily what they're telling people. They're not really giving people other options. Not to say that there aren't other options. And FIT testing is also considered first line. Kind of interesting, Cologuard is not. And I think just because that's a little bit newer. You kind of look at the specificity and sensitivity, Cologuard is pretty similar to FIT testing. So I'm not really sure why it's not first line for them. I think maybe that will change at some point. So this is kind of screening intervals based off of what you're going to use. So for colonoscopy, and you don't really have to know all of these, but I think it's helpful to kind of look at them and say, why did they tell me 10 years? Why did they tell me 5 years or 3 years or things like that? And sometimes what happens is, and I feel like a lot of the time, maybe Jeff can talk to this too, but they come back from GI with a colonoscopy report and it's like tubular adenoma and they don't give you a screening time. So they send that to the patient saying, oh, recommended 5 years, but sometimes we don't get that. And so we do often have to request it. But I think it's helpful for you to know if they had a tubular adenoma, which is a precancerous, lesion in the colon, that they're going to go back probably sooner than 10 years. So just something to kind of keep on your radar. And that's something I tend to keep kind of in like the problem or the surgical list, like colonoscopy in 2015 they're doing in this year, just so it's easier for me to kind of keep an eye on that. Do you do much FIT testing, Jeff, in the office?
I do almost none.
Okay. Yeah. I don't really do a whole lot of it either. I know David does a lot of it. you know, as far as if you're having people do colonoscopies, you don't have to do FIT on top of that. That's not the recommendation. I think some providers do it just to feel like they're doing that extra step and making sure, but it's really not a recommended thing. And then Cologuard, I use a lot in primary care. I did not use a lot in GI just because, you know, when they're coming to you at GI, I think it's kind of like, okay, this is what we do, right? So in primary care, Cologuard is that, you know, that thing that if you're not going to do anything else, can we get you to do the Cologuard? And at least we can have some sort of screening, because all the GIs say, you know, some sort of screening is better than no screening, right? So this is a chart of age-specific colon cancer incidences. This is older as well. There's not a ton of like newer research right now, but just showing kind of how the incident rates increase as you age. You can see like 45 to 49 that there is a little bit of a jump there. It slowly kind of creeps up even after 30. But I think that's kind of where their push was to go lower for screening. And it's like, as far as, let me just go back to this one here. The actual rate of colon cancer has gone down by about, I think it's about 2% in the last 10 years or so. But the actual rate under 50 has gone up about 1.5%. So we're seeing less of it in older people and a little bit more of it in younger people, but overall that rate's decreasing. So it is something to kind of keep on your radar, because I feel like, you know, when someone's in their 40s and they have something going on, it's not typically our first thing to think about, but it is something that you should be thinking about. This talks about just kind of how we go from normal colon to a carcinoma or an adenoma. So, you know, basically like any other type of cancer, there's, you know, mutations that happen, overexpression of things. And so going from a small adenoma, which is what ideally we're trying to remove on colonoscopy. So we're trying to find those small tubular adenomas, serrated polyps, and remove those, because that's what turns into, you know, larger adenomas and carcinomas. It does take a long time. So it takes 7 to 10 years, and only about, like, it's less than 5% of those polyps progress. So I think people rush to say like, oh, I have this new change. It's been a year since I've had a colonoscopy. I'm super worried. The likelihood of that being something like a carcinoma is really low. I mean, it can happen. Because if you look at this, right, it takes 7 years for that to become a cancer. So if we're doing regular screening, you know, hopefully we're picking up most of these people. As far as high risk patients, so all those kind of screenings were for average risk patients. They don't have, you know, any family history of colorectal cancer. They don't have active inflammatory bowel disease. People with inflammatory bowel disease are at higher risk for colon cancer. So they are people who get screened more frequently. And that just kind of depends where in the colon or the small intestine you see that. But so for high risk patients, this is an advanced polyp or colorectal cancer in 1 first-degree relative less than 60, or 2 first-degree relatives at any age. I find it hard to get from patients, you know, like, does a family member have a polyp? Like, do you know if they've had an advanced polyp? And I find that's not something patients really know. So most of the time it's asking about, you know, colorectal cancer. For those people, you're going to start at age 40 or 10 years before their youngest relative. And that's somebody you want to be screening every 5 years, even if they have normal colonoscopies. For someone who has a first degree relative over 60, they still recommend starting at age 40 or 10 years before. Not sure why they say 10 years before, because if they're over 60, or doesn't make a whole lot of sense. And then those people can kind of resume regular screenings. They're not as high risk as someone who is younger. Cologuard's not recommended for these patients. So anybody who has, you know, family history of colorectal cancer, I don't typically offer Cologuard to. Anyone have any questions about kind of colon cancer screening or anything like that.
Sarah, this is Jill. I just had a question about, you talked early on about not doing the colonoscopies at a later age, and
Yeah.
if they were healthier, the doctor might do them, but like, can you speak to just exactly what might happen to the patient if they had a colonoscopy? Like, I was a little unclear about that.
Yeah. So like if they had a colonoscopy, like what, over 75 or 85?
Yeah. Like,
Yeah.
is there like, does it put them at risk for something else, or just the anesthesia part, or?
Yeah, it's really just like the risk of the actual procedure itself.
Okay.
So, they have to have propofol. So like, do they have lung disease? Like, are they, or do they have heart failure? And so like in the case that, right, they don't do well under that medication, do we have to give them more medications to make them better
Right.
for that
That
stuff?
makes total sense. I just wanted to clarify exactly
Yeah.
what the risk.
And then
Okay.
kind of like other risks just to think about for colonoscopy, because I think a lot of the time we're just like, oh, this is what we do, right? But I talk sometimes to people about there is a risk of perforation, there is a risk of bleeding. I have seen a lot of people where a polyp's removed that they end up with bleeding and they end up in the hospital, in the ER for bleeding. So those are risks. They're very low risks, and but it is something to talk about with your patients.
Yeah, it makes sense. I just, because I've had patients be like, well, why don't I need a colonoscopy? Don't you need to check my colon? And I wasn't quite sure. Thank you.
And at 75, I mean, you can definitely, if it's someone who's healthy and they want to have a colonoscopy, you can refer them, right? They can have that discussion with the GI doctor. Same thing at 85. Like I said, I've seen people who are in their 90s and like maybe one person had one, but they were pretty healthy. So
thank you.
And then is also the question, if a colon cancer is found at age 85, what are they going to do about it? Like, are they really going to want to go through that type of treatment? And, it's kind of like looking at the next step too, I would think.
Yeah, definitely. And like, I talk a lot about like, even, all screenings, right? Like, what is our point in doing this? Like, are you going to do anything about it? Do you want to have a surgery if that's the case? Do you want to have all these things, or are you pretty happy with where you're at? And I think that's, those are kind of the discussions I would have with people.
One of the other things to think about is, and these are statistics that I've heard at some point, so forgive me if I'm a little off, but one of the things that has been said over the years is that if you don't do colon cancer screening in the next 10 years, if you say start at 50, 8 out of 1,000 people will be dead at the end of that 10 years. If you do colon cancer screening, only 1 out of 1,000. Now, that's 7 out of 1,000 that you saved, but that's 993 out of 1,000 that it really did not have any benefit for. The one that would have died anyways. The other 992 would have lived anyways. So that when you're looking at something that has a relatively modest yield like that, again, if you're 50 years old and you're healthy and it's easy to do, that's great. If you're 75 or 80 and like Sarah says, you have comorbidities, the prep is actually the thing that I'm the most worried about with these people, just because, you're washing them out. Some people will stroke out. Some people will have, substantial complications even just from the prep. So, the procedure is one of the things to think about. The perforation rate, I think, is 1 in 500,000. So it's not zero, but it's not particularly high. But when you're looking at something that has a real benefit, but a relatively modest benefit, you just have to, estimate that. The American Geriatric Society says that if someone has a greater than 10-year life expectancy, it's worth seriously consider doing it. But for the average person, 10-year life expectancy, if we think that both men and women live to around 80, women usually live a little bit longer and men a little less, around 70 or 75 is the time to be having that conversation. And like Sarah says, if you got somebody that's still running marathons and really healthy, that's one thing. But the majority of people, especially that are seeking out care, are not necessarily those people. So just to provide that other context.
Yeah, that's a good point about the prep. I didn't even think about that, but that is a big issue. And I think even with not older people, right? So like people who have are chronically dehydrated, I've had them end up in the hospital because they've passed out, or their kidneys, they go into acute AKI. So it's definitely something to think about. And a lot of people don't want to do it because of the prep. They're like, I've did it once and I'm never doing it again. There are some kind of other preps that are like, there's the SU prep, like there's some different options at the GIs, but I don't find they're very good at offering those to people. It's very like, this is the prep I do, and they have their medical assistant just basically like mail that to the patient, and that's what they do. So you kind of have to push for that. But
yeah, I had that conversation with Brian Hyatt not long ago, because I have a lot of patients that kind of like the Miralax prep, and feel like it's a little gentler. The problem is he's like, well, I don't think I get quite as good visualization. And I'm like, well, but if people, is it good enough? And he was kind of feeling like, well, yeah, it's probably okay. And if people have a much easier experience with it, I think I'm going to ask for that one the next time I have one. But fortunately, I'm still a few years out. So
yeah, and what was I going to say as far as the Miralax? As far as some people, if they're chronically constipated, those are people I talk to about like, let's do Miralax for a week before and get you cleared up, because some of those people go in there and they can't do the colonoscopy. So they did this whole prep and they still have stool in the colon. And so it's frustrating for people to, have someone drive them there and have the whole day off and set up. And then they're like, we can't do it. And you have to come back. And so that can be frustrating too. So I often have people do, Miralax for a week beforehand. If I know, the GI will not typically tell them that. So that's the hard part about if you're seeing the patient or not, but yeah. Okay. So we're going to go into diarrhea. So this is 35-year-old female, presents with diarrhea for about a month. She's had 3 or 4 loose stools a day, notes some mucus on the stool. What do you guys want to know from her?
Any blood in the stool?
Good. Okay. How about just like,
Does she feel weak, or how's she feeling? Does she feel weak, like she can't walk, or?
I would want to know if she has abdominal pain with it, if she's relieved, if the abdominal pain is relieved by defecation.
Good. Okay. So yeah, associated symptoms, as far as blood in the stool, things like kind of doing a good review of systems. Any other like social history, family history, like would you guys feel like you wanted to ask her?
Maybe past surgeries, like if she's had her gallbladder removed or anything like that.
Good. Okay.
Recent travel.
Awesome. Good. Okay. So this is kind of as far as like pertinent stuff. So family history, I always ask these people any history of colorectal cancer, any family history of inflammatory bowel disease, so ulcerative colitis, Crohn's disease. Social history is also good, just, as far as sexual partners. So she's in a monogamous male relationship. She has a daughter that's 5. She has 2 dogs. She's had no recent travel, no medication changes, which is a big one. I always ask for these people, anything over the counter that you started. Sometimes I actually saw this a lot in GI, people who were eating like sugar-free gum all the time or sugar-free things. There's actually a little bit of a laxative in that. Any diet changes. So like, did you start eating differently? So for her review of systems, she denies any fevers, chills, weight loss. I always ask kind of systemic symptoms, and then kind of more GI specific. She doesn't have any nausea and vomiting, but she does note she had a GI bug about a month ago. Her daughter got, she denies any dysphagia, heartburn, melena, hematochezia. on exam, looks pretty benign. She has no abdominal tenderness, guarding, rigidity. So I want to kind of just go through differential for diarrhea. There's a lot of stuff that can cause diarrhea. And so I think this is kind of overwhelming sometimes. These are kind of the 4 categories that I always think about for diarrhea. So infectious, could this be viral? Could it be bacterial? These tend to be things that, resolve after a few weeks. Inflammatory, so microscopic colitis is something that I don't think I really knew about until I worked in GI that is very common. It's something that causes really severe frequent diarrhea, tends to be like with, sometimes people have a medication change. It's not always a clear reason, can be antibiotics. The hard part about microscopic colitis is that we can't actually see anything. So even if, they're going into the colon and it looks like microscopic colitis, they're not going to see that until they take a biopsy of it and look at it under the microscope. That's when they determine it's microscopic colitis. We can talk about that more if anybody's interested in that. Other inflammatory bowel disease, which I think you kind of, ulcerative colitis, Crohn's, which we'll talk about more later. And then malabsorptive issues. So celiac disease, which is actually something else you should probably talk about. Family history I didn't put in there. Post gallbladder, like somebody said. And then the other one, pancreatic insufficiency, which we don't deal with a lot in primary care. I think this is a lot of, occasionally I'll order this. You're going to see people who complain of really greasy stools. There is a specific stool test called a pancreatic elastase that you can order to check for this, but it's not always helpful. And then functional, which is, I would say, most of our patients that we see with diarrhea. So irritable bowel syndrome, functional diarrhea. So evaluation for diarrhea. So I don't tend to do any testing on people until it's been over 2 weeks, because most of the time, right, it is something viral or bacterial, unless it's really severe. Someone comes in, they're like, I'm having 15 bowel movements a day, or I'm having any red flags. So that would be, blood in the stool, severe abdominal cramping, fevers, any of those systemic symptoms, and I would test sooner. So the stool testing that I typically do for these people, stool culture, giardia, oven parasites, which they do recommend, but I don't find I don't think I've ever seen that come back positive. C. diff if they're having watery stools, recent antibiotics. And then the other one that I didn't find people are using a lot in primary care is fecal calprotectin. I don't know if Jeff can speak to if he uses it at all, but it's a really helpful inflammatory marker for inflammatory bowel disease. So it's the most sensitive marker that we have for that. You can do a CRP and ESR, but it's not sensitive for inflammatory bowel disease. This actually shows us there's inflammation going on in the bowel, and that can actually be elevated in microscopic colitis as well. So any sort of colitis that will show up as elevated. So I tend to do that in a lot of people, especially if they have mucus, they have blood, they have a family history of inflammatory bowel disease. Lab testing, most of the time will do celiac testing, especially if they have a family history, a BMP just to check for like electrolytes, and then a CBC mostly to check for, do they have iron deficiency or something more concerning. And then you always want to make sure they're up to date on their colon cancer screening. If they're not, obviously you refer them.
So just to answer that question of whether I do the calprotectin, I never did it until about 5 years ago. And one of the students was working with a GI, and basically we kind of went through the student and said, do the GIs want us to have that done before they see the person, if it's somebody that you're really thinking, may have inflammatory bowel disease. And I did actually start doing those at that point. The fecal elastase is an interesting test. I've probably done 8 in the past 4 years. I've had 0 cases of exocrine pancreatic insufficiency. I have had 1 case of colon cancer, because this man came in and said, my wife has EPI. I'm sure I've got it too. I'm having loose stools. They're kind of oily. I actually did a calprotectin and a fecal elastase on him, and both of them were quite elevated. So I sent them to GI. and they scoped him and found a cancer. So, you know, a lot of these tests are relatively non-specific, but if they are abnormal, it's a really good reason to refer.
Yeah, and I think the calprotectin is right. Like, it's one of those things that it helps us to say, like, do they need to go to GI or do they not? If their calprotectin is super low, then I'm like, okay, we probably keep them here and kind of try some things. If it's not, there's some sort of inflammation going on, whether that be colon cancer or colitis or inflammatory bowel disease, to send them. So I do think it's something that honestly they check on pretty much every single person who comes in with diarrhea. So I tend to order it a lot just because of that. And it makes me feel better too, to be like, this probably isn't something inflammatory. You know, and sometimes you'll get those people where the lab tends to say normal, you know, mildly elevated and elevated. And so those people that are mildly elevated, sometimes what I'll do is just recheck that, you know, in a month or so. And if it comes back to normal, I don't worry too much about it. If it continues to kind of creep up and they're still having symptoms, then I'll send them to GI. So yeah, let's go through the case and then we can talk about if anyone has any other questions. But so this lady comes back, all of her testing came back normal. So she had normal stool tests, she had normal lab tests. We did kind of all those things. What do you guys think could be going on, and how would you talk to her about kind of like what we would do for treatment? Anyone have any thoughts?
I would, you know, like JJ said in the comments, like talk to her about her diet maybe, and go that route and see, you know, like maybe if there's a food elimination thing we can do, or some triggers or something specific. Think more like functional stuff.
Good.
Maybe.
Good. Okay. Anything that you would offer her? I know as far as we'll talk to her about her diet and stuff, but is there anything you think that you would give to her to help with the diarrhea if she's kind of bothered by it?
Could she do like fiber and or probiotics to kind of reset her gut after she had a viral illness?
Yeah. So this, in this case, and I see this a lot, most likely this is like a post-infectious irritable bowel syndrome. So oftentimes I see people who come in with a GI bug, and then, you know, like for a few weeks to 6 weeks, they have this kind of like change in their stool. And so oftentimes what I'll do is I'll actually, first thing will be like, I'll have them start a fiber supplement. And I talk to a lot of people about that. They're like, well, that's going to give me worse diarrhea. And it's not. I mean, what should happen is it should bulk up the stool so that it makes it so that it's a little bit less loose for her, and hopefully she's not going as much. So that can be Metamucil, it can be Benefiber. One thing I will say about fiber supplements, GI hates fiber capsules, tablets. They like the powder. And I think it's just because it tends to work better for people. So sometimes I'll offer gummies if they don't want to do the powder, but I tend to stick with kind of powder gummy kind of thing. I also talk to people about when they're starting fiber to start kind of slow and building up. So you don't want them to go into taking like 2 huge scoops of it a day, because they're going to feel bloated and really uncomfortable. So I usually say take half of what it's recommended on, depending on which one you take, and then kind of work your way up over a few days. Other thing that can be helpful there, some people are like, I hate Metamucil, it's jelly, it's orangey, you know, so I offer them Benefiber because it doesn't gel and it doesn't taste like anything. So I think just kind of like knowing what's out there and kind of talking through with people is helpful. The other thing in this case, right, she's not having any bleeding. All of her labs are normal. You could have her try Imodium if she's really bothered. So if she needs to go somewhere and she's worried about going to the bathroom, you know, you can have her do an Imodium. Sometimes that will bind people up for a day or two. So you can kind of warn them about that. I tend to, the dosing on that can be a lot. Like you can do 2 tabs initially in the morning, and then like 1 tab 2 or 3 times during the day. I usually just have them try 1 and kind of see how they do, and then they can do more if they need to. And then for her, I would probably say, like, let's try this stuff. Talk to her about kind of diet changes. Think about maybe doing a food log or food diary to see if there's something that's bothering her. have her come back in, in 6 weeks and kind of just check in, or have her call and say if she's improving or not. And if she's not, kind of, look at what else this could be. What do you think would change? So if she had a small weight loss, say she lost, 10 pounds over the last month, and she did have a mildly elevated calprotectin, what do you think? What would you do?
I think since she's been having the diarrhea for so long, that might be worth sending her to GI.
Yeah. So these are kind of the red flags, right? So like she's lost a little bit of weight, her calprotectin's a little bit elevated. So, I mean, the concern there is inflammatory bowel disease, or some sort of process that's kind of causing that. So I would refer her to GI for she probably would get a colonoscopy by them, but you don't even have to make that determination. I would send her. So
you wouldn't order the colonoscopy and refer to GI at the same time. You just leave it for GI to decide kind of what to do.
Yeah, I would just put it over as a consult, because usually when I order colonoscopy, it just tends to be for screening. So for them you want them to look at them and say, what do I want? Right. Because they may want an upper endoscopy. They might want more testing done. So I just put it over as a consult for things like that.
That makes sense. Thank you.
Yeah, of course. Any other questions? We're going to kind of go into inflammatory bowel disease, but questions about that.
So I just had a couple of comments about diarrhea, just because, I'm old and I've been doing this a long time. So I love Imodium in people like this. I usually use half a tablet. I make sure that there's no signs of C. diff. The 3 that I specifically ask about are mucousy stools, really foul smelling stools, and have you ever lost your stool? Because lots of times people with C. diff will have a little bit of incontinence, and that's a real tip off for me. History of antibiotics obviously is a great thing to ask about, but I've seen people have C. diff even without having been on antibiotics. So I had a question, Sarah, too. You didn't include a stool for white blood cells in your workup. Was that something that has fallen out of vogue? The challenge is that, people will go to like the ER or a walk-in, and they'll order a stool culture, stool for white blood cells, O&P ×3, C. diff, and Giardia. And then, usually all these tests will come back negative, and then they'll come see you in the office. But,
I just find it's not very specific, right? So it's just, what are you going to do with it? What is it going to change what you're doing? I think some of the GIs will order it, and some of them, a lot of them didn't. Because if you're getting what you need out of these, right? Like you're making sure there's no infection, there's no Giardia, there's no parasites, if you get the C. diff on there, like how is that really going to help you? That's kind of how I've looked at it. So I don't tend to order it, because even if I see it, I don't know as though it's going to change what I'm doing.
Well, and I pretty much agree with that, but it's one of those things that unfortunately,
it's done. Yeah.
It's one of those things that we all learn, and to do stool cultures as soon as they have diarrhea. I tend to wait at least 3 to 4 weeks.
Yeah.
If they have stools more than 6 times a day, Sanford says you can go ahead and empirically treat them with 3 to 5 days of Cipro. And I do that on a fairly regular basis, with pretty good success. Obviously, if they're, bloody diarrhea or whatever, or any chance of C. diff, all bets are off. But I don't remember the last time I ordered stools for O&P. I just think it's absolutely useless. The times that I did it, I was looking for Giardia, and now that there's a Giardia antigen test, I don't see a role for it. But you see it done all the time, and as you say, I've probably seen it done 20 times in the past 5 years. 100% of the times it was useless.
Yeah, exactly.
So.
I don't think I've ever seen it either. The other thing that GI, at least the GI practice around here has, is they have a diarrhea panel that they send out, and it tests for like a billion different things. So it tests for all those things we were talking about, and stuff that you don't even probably think about or know about. And I think sometimes it's helpful, like for the EPI stuff, but so some of these people, like you'll do this workup and like they'll go to GI and they'll probably get stuff again. And it just depends on the provider, if they're willing to kind of get that stuff, or if they don't see it, they'll oftentimes just order it again. So wouldn't worry too much about it. If you're sending it, like, I need to have this done before sending them, I wouldn't worry about that. But yeah, I think the O&P, I think me and Rachel just had a patient too, like last week, that had diarrhea, and we didn't order it either, because it's like, you know, what is the likelihood of this being something like that? Very low. So I don't tend to order it a ton either.
Another thing to think about is when they do stool cultures, they tend to look for Salmonella, Shigella, and 157 E. coli. They don't look for Campylobacter. There's a lot of things that can be in that stool that they're not even looking for. And even though the stool culture comes back negative, if you've got somebody that has, say, a traveler's diarrhea or something, and you put them on Zithromax, they just get better, and you're like, they must have had Campylobacter. But yeah, unfortunately, it's a blunt instrument.
Yeah, and I think for those people right there, they have that positive social history, they have the travel, then like it's fine to treat them and just like not even, I don't know, Zoe, we'd even do this, right? Just treat them, see if they get better over a few days, and then if they continue to have diarrhea, test for stuff. But I think it's just kind of a waste of resources if you know they traveled.
Absolutely.
Yeah. Okay. So let's go out. And yes, I think someone asked about the O&P has to be × to rule out. It technically does. If I've ordered it though, I don't tend to do 3 of them. I'll just order 1. Like you said, I think it's just not a very helpful test. And it's like such a pain for patients to have to do that many of them. Like they're already going home with a million things to do for diarrhea, and they get overwhelmed by that. But, okay. So inflammatory bowel disease, ulcerative colitis and Crohn's, just kind of like a brief, I won't go too in depth to this, but so red flags, kind of when to suspect. So this is kind of on top of like, diarrhea. Not everybody with Crohn's has diarrhea though. So just something to think about. So red flags: weight loss, ongoing rectal bleeding, mucus in the stools, tenesmus, which is kind of like a spasming, cramping of the rectum, family history of inflammatory bowel disease. And then we talked about that fecal calprotectin. If they have an elevated CRP ESR, which sometimes happens when you're trying to figure out what's going on. And I've had patients that they can't figure it out, and they're like, send them to GI, maybe they have this, and order a calprotectin. Those are not very specific though. So the hard part is like, where is the CRP ESR coming from? It may not be inflammatory. And I think a lot of that gets really skewed sometimes with people who have like multiple autoimmune disorders, which is very, very common. So just kind of briefly talking about like inflammatory bowel disease treatment. So I'm sure you guys all kind of are aware of, if someone has a flare, they tend to use prednisone. There's also something called budesonide or Euceris. I'm not sure you guys have heard about. It's a steroid that's actually more, it's more targeted to the gut. So it's not supposed to be as systemic as prednisone is. So for people who have diabetes or they have to be on this long term, it's supposed to be better. I will say a lot of people don't tend to do as well on it. So sometimes they'll get switched off of it pretty quickly. It's also very expensive. So some people just can't afford it. As far as kind of like, so someone comes into your office, right, with a flare up of inflammatory bowel disease. That is not someone you want to start prednisone on. That's someone you want to have them check in with their GI doctor and kind of talk to them about. GI does not like to start prednisone for flares until they kind of talk with them, assess what they're doing. And oftentimes they want to have them do a colonoscopy or some sort of testing beforehand. And the reason is because they don't know how bad the flare is, what medication they're on, is the medication working? So if you put them on prednisone and it slowly kind of treats that flare up, they don't really know what to do. And so a lot of those people, they'll actually fit in for a colonoscopy like that week or the next week, just to kind of, see. So those people should kind of be following closely with their provider. As far as, I have had some people that are like, I don't have a GI, or like, I don't, those people who are very non-compliant and don't go. And I've occasionally done this just to kind of get them through so they don't end up in the hospital and, bleed out or things like that. But just something to keep in mind. Mesalamine is kind of like their first line. It's typically more for ulcerative colitis because it only works in the colon, not the small intestine. I have seen it in Crohn's sometimes, if people have it just limited to the large intestine, but it's not helpful otherwise. That can be done in suppositories, can be done in a pill, and it's something that it's not an immunosuppressant. It's basically an anti-inflammatory for the bowel. And then kind of like step up therapy, biologics, you've all heard of like Entyvio, Stelara, Remicade, Humira, all just kind of depends on the GI doctor, if they want to start higher, they want to start lower, what their flare up is. Things, I know me and Jeff kind of talked about this, but things to kind of think about from a primary care point, making sure that their vaccines are up to date. So if they are going to be starting on a biologic, I often will say, like, let's make sure like you had your pneumonia vaccine, like even if they're younger. So getting them up to date on some of those vaccines that we use for immunosuppressed patients. And then when they're actually on it, being mindful about what vaccines you're giving them. So some of the live vaccines with those are not recommended. Some of the medications also require like annual dermatology exams and things like that. So I would say just being mindful about like when those patients are on those medications, just kind of look at that stuff. They're all a little bit differently. The GI doctor should be honestly, making sure their labs are up to date and they're screening for all this stuff and doing that. But I find it gets dropped a lot. So not that it's your responsibility, but sometimes I will go through this with patients just to make sure that they're kind of up to date on it.
Sarah, would a primary care would never order these biologics? Is that correct?
Yeah, no.
Okay.
Yeah, I would leave that up to GI. You've never ordered it, right, Jeff?
No, I never would. I can imagine if you're like in Alaska or
right,
whatever, you might have to get a phone consult for GI and end up doing some of the management yourself. But anywhere near civilization, I see that as a specialist drug.
Even mesalamine, honestly, I don't think I've ever prescribed that in primary care either. That's something that like if someone has inflammatory bowel disease, you probably shouldn't be managing it, right? The GI should be managing it. They should be doing regular, all this stuff, but it's just good to know kind of, what the medications are and, making sure you're reviewing them with your patients and they're up to date on things. So, yeah. So let's go into IBS, which is like the big thing in primary care all the time, right? So this is kind of the Rome criteria for irritable bowel syndrome. I'm sure you guys have all seen this. So basically, they actually have to have symptoms for quite a while for you to diagnose irritable bowel syndrome. So some of these people with diarrhea, you're like, oh, this sounds like irritable bowel syndrome, but you can't really officially diagnose it. So they have to have recurrent abdominal pain at least 1 day a week in the last 3 months associated with 2 or more of the following. So it's related to defecation, associated with change in frequency of stool, or associated with change in form of the stool. And it has to be within the last 3 months, but also had symptoms for 6 months. So it's, most of these people that are coming to you though, right, they're people that have had this forever. Like I've always been like this since a kid. I have loose stools off and on, or I'm always constipated and, that kind of thing. So workup, we can just kind of talk about like kind of workup for those. So someone who you're thinking has irritable bowel syndrome with diarrhea, the recommendation is kind of work them up like they have diarrhea, right? So do the stuff you talked about before. I mean, if it's someone that obviously like this isn't a new thing, they don't have any antibiotics, you really have to do C. diff testing or like Giardia or things like that. Not necessarily. So I think it's kind of use your judgment on that. But I would, make sure they're, colon cancer screenings up to date, checking celiac testing. I would probably send a fecal calprotectin just to, be on the safe side with that. As far as irritable bowel syndrome constipation, so checking kind of similar things, blood count to make sure no iron deficiency, thyroid, which can cause constipation, colorectal screening up to date. a lot of the GIs, which I don't see it a lot in primary care, they'll do a, abdominal x-ray just to see stool burden. So like to confirm that, right? So I feel really constipated. I have abdominal pain. Like, let's confirm that you actually are constipated. I don't know as though it changes a whole lot of management, but sometimes it makes the patients feel better. Like, oh yeah, they saw that on the x-ray and, we can treat that now. The ACG guidelines recommend against colonoscopy in these patients with IBS symptoms younger than 45 without warning signs. So those are people with diarrhea. So they're saying that even with people who have chronic diarrhea, to be honest, most of those people eventually end up at GI just to make sure nothing else is going on. So you don't necessarily have to, but if you're uncomfortable and you're just not really sure if it's IBS or it's something else, I would just say you refer them, just to make yourself feel better too. So this is kind of this, and I can post this too, but give you guys these slides, but this is just kind of like their decision support tool for treatment. So for all this is people who have diarrhea, who have constipation, who have alternating, which can sometimes be really, really hard to treat. So the first thing is going to be like lifestyle modification. So like everybody else, right? Exercise, sleep, stress reduction, and then talking to them about fiber. These are people I always try to get on fiber supplement. And then the low FODMAP diet. So I think this can be really helpful for some people and it's not helpful for a lot of people. Me and Jeff have talked about this a lot, just like, do we send them to nutritionist? Is it really that helpful? I don't think a lot of the time it is, but I think people feel like they're, being, assured and helping through this process. As far as the FODMAP diet, what I talk to people about is, it's a really hard diet to stick on forever. It's a billion foods that you can't have. So oftentimes I'll either have them, cut everything out of their diet and then slowly kind of add things back in, a week or two at a time, or I'll just say, pick one of those groups and let's cut it out for 2 weeks and kind of see how you feel. And so we'll do it kind of stepwise like that, because a lot of people can't stick to that diet. It's really, really hard. So as far as we kind of separate out, IBS diarrhea, IBS constipation. So we'll talk about diarrhea just because we were kind of on that. But so we talked about Imodium. The other thing that you can think about is cholestyramine or cholestyramine, which is basically a binding agent. We also use it for, when people have had their gallbladder out and they have diarrhea, just to kind of help bind things. It is something that can help lower cholesterol, but it also is not something that you can take with a lot of other medications because it limits their absorption. So you have to be mindful about that. So those are kind of the first line. And then the other thing is if they're having abdominal pain, you could think about antispasmodic. So I'm sure you've heard of Bentyl before. The other one I talk to people about a lot is peppermint oil. So I don't know if you guys have heard of ID Guard. It's a basically irritable bowel syndrome medication that is peppermint oil. It's a delayed release, but it's very expensive. And so that's sometimes the limiting factor, but I do have a lot of people do well on it and just kind of relaxes the spasm. As far as second line, so talking about rifaximin, which is something we also use for SIBO. I've seen some of the GI doctors put people on rifaximin just to see if they could help kind of calm things down. It's definitely not a long-term fix, but sometimes if they're, in a bad flare of their IBS, that will be helpful. And then if they continue to have abdominal pain, like thinking about a TCA, so something like amitriptyline, 10 milligrams at bedtime. I did want to mention this allosetron, same thing with the tegaserod, which is like on the constipation side. Both of those were taken off the market and put back on the market. I would not recommend any of you prescribing them, outside of GI. And the reason is that they have a lot of risk factors. So allosetron has a really high risk of ischemic colitis, which is not something that's very fun. And then tegaserod was taken off due to cardiovascular risk, and then it was reintroduced For women under, I think it's like 60 or something like that, without cardiovascular disease. So it's a very like small amount of people who can take that. But I would just be really, really mindful about those. And I don't think, I think maybe I prescribed it once in GI. So it's not something you'll be around very often. And then switching to kind of constipation. So first line stuff you want to think about, you know, I tend to use Miralax a lot. I find that a lot of people have like, I've tried Miralax, and then you talk to them like, well, what did you do for Miralax? You know, I took it once a week, you know, like that's not very helpful. So talking to people about taking it, you know, once a day for a while. And if they're in a really bad flare of constipation, I actually have people take 3 capfuls that night, and then take it twice a day for a few days, and then kind of back off to once a day. And then we can kind of check in again. And then same thing with abdominal pain. You can do the IB guard, you can do the bentyl, hyoscine. Second line stuff that you can do in primary care for that is like Linzess, Trulance. So those are all help kind of stimulate movement and water secretion. The biggest thing that I warn people about with those is sometimes they can cause too much diarrhea, and they can cause dehydration and things. So those are kind of the big pathways. And I know this is a lot of our patients. So I think a lot of it's like being understanding to them and talking them through this stuff and working with them. You know, if they feel like a nutritionist is helpful, you send them to the nutritionist. You know, it's hard to tell if it's helpful or not, but yeah. Anyone have questions about IBS? I know it's a big.
I do have a question. Sorry to interrupt. These patients are, I think sometimes like difficult because I sense that they're really frustrated with the diagnosis of IBS sometimes, like feeling like it's maybe not correct, or that there are more things going on. And we're sort of just saying like, you should modify your, lifestyle and things like that. So I think these patients are really challenging. And I see a lot of providers sort of use this opportunity to talk about like the gut brain connection and things like that, and stress reduction. Do you find that that's like a helpful conversation or pathway to go down? Or it's really not helpful, or maybe just like in a nicer way that we can reassure them that it's not like that we're, ignoring their symptoms, but that, everything looks good and that this is functional and not like, something more concerning.
Yeah, I think it's really frustrating for people because they're like, I want something to be wrong, right? I want you to tell me like I can take this pill and it's going to be better, and it's not that easy. So I think it is helpful to be like, this sometimes can be, a gut brain interaction, and I think not forcing it on mental health, right? Like, are you stressed out? Are you anxious? Are you like, I think that stuff can be unhelpful because they're like that feels like you're blaming it on that, right? So I think, talking about like what irritable bowel syndrome is, and, how can we treat this, and like, what can we do next, and like trying to just work through them with like a process. So, we're going to try this stuff first. We're going to have you see the nutritionist, see if we can make some diet changes, and then we kind of keep taking steps. And then if you're not getting anywhere, right? Like you've tried all these things. I've tried IB guard, I've tried bentyl, I've tried, all these things. You send them to GI. The hard part is GI is probably, at this point, if it's been going on a long time, they may do imaging, they may do a colonoscopy, those are guidelines, right? But they're not always followed. Sometimes that's helpful for people to be like, okay, like there really is nothing wrong, right? Like I had the imaging, I had the colonoscopy, and sometimes they can accept that a little bit easier. But then they come back to you, right? They come back and they're like, well, what now? And so I think just kind of keep working with those patients. And it is helpful to have those discussions about the gut brain interaction, but I think trying not to like say that it's your mental health and like it's your stress. And, I think it's helpful to talk about, but try not to blame. Yeah.
It is interesting.
Oh, sorry, Jeff, go ahead.
It is interesting because sometimes you bring that up and it really resonates with people. Everybody has a warning light on their dashboard of life. Some people get migraines, some people get diarrhea, some people get whatever. And if it resonates with them, it's really helpful and you can go down that road. I've actually been shocked how many people, because I start a lot of people on amitriptyline for migraines or for sleep or for whatever. And it's been very interesting to me, the number of people whose GI issues got a lot better on it. It's also useful even for chronic cough. I actually take it for chronic cough, and you know, it's a very interesting medicine. And like you say, even at 10 milligrams, it can be pretty helpful for people. But you got to kind of meet people where they are, and some people those discussions really resonate, and other people not so much.
Yeah, and I think the other thing that, and I have another slide on like functional abdominal pain, which is kind of similar to this, but without diarrhea, constipation. But I phrase these things as like, so like, let's start you on amitriptyline or something like that. I don't say like, this is an antidepressant. I say, this is a neuromodulator. And, you know, this is what this does. I use this for people who have, you know, chronic migraines, who have chronic pain. And I go through that kind of like, this is not just like you're crazy, right? And I'm giving you amitriptyline. The neuromodulators help with this gut-brain interaction, you know. So I try to go through that with them, and I think that does help a lot of people to be like, okay, I'll try it. You know, not to say it's going to work for everybody, but I think it, you know, if you're just like, this is an antidepressant, try it. Like they're going to be like, no, thanks, right? So I think just how you word things and like listen to them and let them get that frustration out is really helpful. So did someone else have a question?
Yeah, I was just wondering, especially with older patients, I feel like the scale can kind of tip and people become really reliant on Miralax, like daily use of Miralax. So what is your recommendation for saying, I guess 2-part question. So how long do you normally recommend that they do that for? And then if they've done that for too long, weaning them off of that daily?
To be honest, I'll keep people on it forever.
Okay.
I'm not really that worried about the Miralax. I mean, unless they have other issues and like you want to make sure they're not, you know, getting dehydrated or things like that. But it's the safer option than like even being on Linzess, right? So I talk to people about like, if this works for you, like, you know, we can just kind of tailor it to how you're doing. Like if you need half a cap a day, if you need a cap every other day, just to kind of keep you moving. Obviously, like those people, you want to try to make sure they're on their fiber and they're hydrated and that thing. But most of the GI docs, like they'll just keep you on it till, you know, if that's what's helping you. Yeah.
If you look at the literature, though, it actually does tend to discourage that because of so-called electrolyte abnormalities. And I do think it's worth, you know, checking electrolytes, you know, a couple of 3 times as you get them started. But I've never actually seen that happen. Have you, Sarah? Like
them checking that stuff?
No, like somebody having an absolute issue with long-term Metamucil. I have lots of people that are on it long-term, even kids, you know, which raises the issue of the X-ray. I do a lot of KUBs in kids with encopresis. So that kid that's, you know, 6 years old, off to school, doesn't like to poop at school. They'll start backing up their stool. They'll start getting stains on their underwear. You know, those kids, you can put them on Metamucil. I usually clean them out with Milkamag or something stronger and then put them on a maintenance Metamucil. And they can stay on it for several, you know, years even. And I've never had any problems, although, you know, you do look out for signs of electrolyte abnormalities, and the literature is not thrilled with us doing it, but pretty much everybody does it. So
I think like from a GI perspective, right, it's like the least harmful. So like if that's what's going to keep you from having an obstruction or like, you know, all these, you know, abdominal pain, then they'd rather you be on that stuff. And that is something to think about too with people who are constipated and you're putting on like amitriptyline. It actually can make constipation worse sometimes. Right. So it is just something to like, I don't tend to like make that a big point. And like when I'm talking to people about it, because then they're like, I don't want to take that. Right. So, but just, you know, make sure that they are moving their bowels regularly and just kind of keep an eye on that stuff. So, yeah. All right. So let's go on to SIBO, which is like the new big thing, right? So there is actually a guideline out about this from the GI. The hard part about it is that there's not a ton of research on it. So treatment, you know, things like that. If you look at the actual guideline, a lot of it is not, it's, you know, recommended advice. It's not supported by like this high quality evidence. And so the hope is that a lot of this will, you know, they'll do more research on it to be able to say like, this is exactly how we should treat this. So it's defined if it is excessive amounts of bacteria in the small intestine, typically gram-negative, aerobic, anaerobic microbes that ferment carbs and produce gas. And so that's basically the symptoms of SIBO, right? Bloating, gas, distension, flatulence. Some people do have diarrhea, abdominal pain. So how do we look at this? And I will say, like, from a GI standpoint, this is not the first thing I used to like talk to people about, right? Like if they come home with gas and bloating, like I feel like this sometimes opens up a can of worms for people. So you just have to be a little bit mindful about it. So for evaluation for it is breath testing, which the GI practice that I was with would do in the office. It is pretty intensive. So it requires like 4 hours of them sitting in the office. So it's a long time. So it tests for methane and hydrogen. However, if you look at some of the research, they're saying that we're probably missing some of these people because it's not checking for sulfate bacteria. So I think that is kind of a future recommendation as to kind of how can we test for that and what other markers can we use, because this test is not perfect. So as far the right side here is a graph of what a test would look like for someone when we were doing SIBO. So the top part is hydrogen, the middle is so hydrogen positive. So someone who had a positive hydrogen, this basically is, and they differ. So if you're looking at hydrogen versus methane, and they typically test for both when you're doing the SIBO testing. So hydrogen has to have an increase in over 20 parts per million in 90 minutes. You can see here this huge jump. Methane, which is the second one, has to have greater than 10 parts per million at any point in the 90 minutes. So this one has a jump here. This bottom one here is someone who doesn't have SIBO. So you can see that they're pretty, you know, they don't have a big increase in anything. So for both of these people, this is probably two different tests, but if they were just hydrogen positive or just methane positive, that we would treat them for SIBO based on that.
Are they ever positive for both?
They can be, yeah. I have seen it, someone who's had both, and they're probably pretty symptomatic. So antibiotics are still recommended as first line. I have had some people recommend just FODMAP diet, but if you look at the guidelines, they do recommend antibiotics. The hard part is, like, if you look at this chart here, like, which antibiotic do we use, right? Like, there's not really good research on this. Rifaximin tends to be the one that we use the most for this, and that you've probably heard of. It's very expensive, like thousands of dollars. The way I used to get it for people was actually through a drug rep, with the drug rep would hope that you would prescribe it a second time and that the patient would pay for it because it was so helpful. So it's not always something that is feasible for people. If you look at this chart too, it's kind of crazy that they put this in here, but if you look at it, Bactrim seems to be a pretty 95%. I tended to use like Augmentin as second line just because, like, that's what the guidelines would recommend. But if you look at this chart, it's just all over the place. So it's not very clear. So I think honestly, like, looking at up to date or things, trying to get rifaximin, but if you can't, going to Augmentin or Bactrim or something like that. The other hard part about SIBO is that it often recurs. And so they do recommend retreatment. However, there's really no data to support that. There's not a recommendation to retest people after, but I think a lot of the studies will try to retest just to say, like, the antibiotic worked or not. And then, like we talked about, the low FODMAP diet, there's also not a lot of research on that, but it does make sense that you don't want to be giving people things that are highly fermentable because that produces more gas. Same thing with probiotics, really not a whole lot of evidence, but sometimes people will use them. So that's kind of my spiel on SIBO. I know it's not super helpful because the evidence is not great, but I will say that, it is being tested for people who have this chronic kind of bloating, flatulence. and that we tended to use rifaximin or kind of second line antibiotic if not. So the other thing I know somebody had asked about was this like leaky gut syndrome, which is like a little bit similar to this, but as far as GI, it's not being talked about. It's not something that's really recognized, from their point of view. And I did try to see if there were like any guidelines or anything from any of the organizations, and there's really not. I think the same thing. It's kind of one of those like future, like, let's look into this stuff and see if this is all connected. The other thing about SIBO that I had looked at was that maybe SIBO is just like this group of disorders we're talking about, and eventually we're going to find the bacteria that are causing this, and it'll be called something different. So I think there's a lot of research to kind of be done on that stuff.
Sarah, what's the duration on some of these antibiotics? Like, if you're going to put somebody on Bactrim for SIBO, how long would it be for?
Yeah, I'd have to look it up again. I think rifaximin is like, I think it was a long time.
Yeah, I just looked up, like 7 days of rifaximin is like $2,300.
Yeah.
On GoodRx, that's with a 20% discount.
Yeah, it's yeah. I would say like probably half the people we tried to put it on couldn't do it. And I think it's 2 weeks to be on. Yeah, 14 days. So it's double that.
Yeah, but you're not seeing anybody use Bactrim, huh?
I think it's so all over the place, right? It's just, I think a lot of it is like, oh, I've used this and it worked well for that person, so I'm going to use it again. So I think it's not very standardized. So I think rifaximin is standardized and that's what we go to, but like even based off of this chart, right? Like it's not great.
Right. Huh.
And I saw that in practice too. It's like some people are like, oh my God, I feel amazing. And some people are like, I didn't really feel anything. And like, I just wasted, $2,000 or whatever, most of those people weren't paying for it, but, yeah. So I think that's the frustrating part is we just need more research on like, what are we actually treating and what is helpful, because the studies too, it's just like, they're so all over the place with like, did they retest? Did they not retest? Did they just go based off of symptoms? And could it be placebo? Probably. So it's hard.
And it's hard to think about researching leaky gut, because allegedly leaky gut is the junctions between cells in the intestines actually start to widen a little bit. There is some evidence that does actually happen in some people. The challenge is that the speculation is then that certain toxins move through those and get into the system. There's not a whole lot of sort of scientific research evidence that that's real, but there are people that very much believe it, and there's some people that use a lot of, to be honest with you, a lot of similar type dietary and behavioral interventions for it. It's very big in the naturopathic community. The naturopaths believe in it very strongly. It's an interesting theory, but it's like many things that are theorized to work in a certain way, whether it actually works that way, I think is an open question.
Yeah. It's just hard. I think it's hard for them too. Like they're not going to talk about that stuff if they don't have the research to back it up, and how do you treat it and things like that. But be interesting to see over the next few years where that goes. So good. Okay. So we're going to go into reflux stuff. So 53-year-old female presents with epigastric burning ongoing now for 2 to 3 weeks. She's had this in the past, but it would quickly resolve with Tums in a few days. Denies red flag, so persistent vomiting, dysphagia, melena, weight loss. She's gained about 15 pounds in the last 6 months. Exams unremarkable. What do you think you would do next? Any thoughts?
Sarah, it's actually a little bit before 10. Maybe we should let them think about it for 10 or 15 minutes over their little break. And then we'll come back with them all inquisitive and with great questions. You want to do that?
Sure, sounds good.
All right. So everybody, will see you in, I've got 9:58. Let's see you at, 10:12. How's that sound? All right. See you then.
See ya.
Tell me if I'm talking too much, Sarah.
Oh, you're fine. I think it's helpful to kind of.
So, some people are listening, and that's fine. But what do you think of Metamucil gummies?
I'll use them for people like the fiber. Yeah, I think it's like Vita Fusion too.
Yeah.
I'll use those for people who really don't want to do a powder.
Right.
But I try to get people to do the powder.
I think they have an artificial sweetener in them too, which almost seems to defeat the purpose in some people, right?
With diarrhea, yeah.
Right. Right.
If it's people who are like constipated and they're just taking it all the time, that I don't worry too much about. But I don't have good luck with the capsules, and I know most of the other providers won't recommend that either.
Right. There are some people that's all they'll do. And like you say, the perfect is the enemy of the good, but they're not even that good, I guess, huh?
Exactly.
So, all right.
How much more time do we have?
We'll go from 10:12 till 11:30.
Okay.
Okay.
Yep. I can always get through it all. I can always just post them. So.
Okay. What slide are you on?
I'm on 22 of 62.
Oh, all right.
But let me see. So this is like GERD and peptic ulcer. So we can go through that quickly. And then I have diverticulitis, rectal bleeding, hemorrhoids. We kind of talked about functional abdominal pain, so you don't have to go into that. And then the last part was, I think it's helpful, but like gallbladder, pancreatitis, fatty liver.
Fatty liver, I think, would be good to talk about because it's so common.
Yeah, and I talk about like the FIB-4 score and kind of all that. So I can try to like skip through some of that other stuff quick.
All right. Well, I'll try to ask less questions, but No,
I think it's helpful. So
sounds good. All right. See you at 10:12.
All right. See ya.
All right, as soon as Sarah gets back, I guess we'll start because it's like 10:13. It's a very nice ceiling fan there. Oh, does anybody know what's happening with the conference this afternoon? I got something from Melody that was talking about you guys doing your exam thing again. Do you guys know anything about that?
We have today to do the Barkley exam because it didn't load into our accounts last time 2 weeks ago.
So and she also
class.
had something about somebody from the Career Center.
Yeah, I think we have a speaker today in class. I don't know if it's a combined class or not.
Did the people from my group get a link from her to?
No, I don't.
No,
And I hadn't heard about the test either. So
me neither.
Want us
Yeah.
to share the link, Jeff?
So
I'll be honest, I can't.
You
I
guys
really
can join.
can't do a test today or tomorrow. So
Me neither.
Career
it's hard
Center.
to do it day of. You know, it's not really fair.
No,
Right.
I'm talking about the Career Center link. Did you guys get that one?
No, we didn't
Like,
get anything.
But I'm gonna text her right now to ask her.
Jeff, can I ask a quick question about the last case study? I don't think I really completely understand, like when it's due and what is it, the one on the?
it's on the blackboard. It's an experiment that I've never done before. There's a lot of really good comments on it. You know, it's intended to keep you guys from having to, you know, do a third case study, to be honest with you. And I, rather than just completely get rid of it, I said, well, you know, let's try it on the blackboard and see. It's intended to, you know, so basically I will post the feedback for that probably on the last day of class.
Okay.
So it's got probably 2 more weeks before I'll be looking at it to see who's posted and the quality of their posts. In general, pretty much everybody's, I'm sorry, accumulated enough points to pass the class. So I'm not worried about that. But you know, as I say, it was an experiment. So take your best shot.
Is that one that's been posted for a while then?
It's been posted since day one. Yeah.
Okay. I just want to make sure that I...
Oh my God, she's underwater.
Because I think the one on the like when I just want.
Yeah, you're breaking up pretty bad. I really can't understand you. I don't know if anybody else can understand her better, but no. Okay. All right, why don't we get back? Sarah's got a lot more to do, so let's go ahead and start. Go ahead and start making comments about her case.
Okay, anyone have any thoughts about this?
Could evaluate whether she's having like a persistent cough. You know, it does kind of sound like GERD in this case. Again, she doesn't have many red flags. The weight loss is, the weight gain is something to consider, but could maybe start the discussion of a PPI and just include in that, you know, doesn't necessarily have to be something that you take lifelong, but if you do stop abruptly, like warning for that rebound acidity there, and just kind of educate her on that.
Good. Yeah. Anyone have any other thoughts at all?
Oh, sorry.
That's okay. Go ahead.
I guess I just want to ask, you know, if something in her diet has changed in the last 6 months that caused the weight gain and also now these new symptoms.
Good. Okay.
And ibuprofen use, if she's had any ortho issues that she's been taking a lot of ibuprofen for.
Awesome. Good.
I'd ask when it's happening. Like, is it at night? Is it during the day? Is it associated with any specific time of day or activity?
Good. Okay. Yeah. All really good stuff to ask. So, I'm going to just talk a little bit about kind of like GERD and like what they consider typical symptoms, atypical symptoms, and kind of like what, you know, what could be causes of this. So like guidelines, retrosternal burning tends to be postprandial. And a lot of people do have kind of regurgitation. I will say a lot of people, you know, don't have the typical symptoms. They complain of like this, you know, some people have this chronic cough, some people have wheezing, some people have that chest pain that they don't actually have the burning. Globus sensation, which is just kind of that feeling of like something's always kind of in your throat. So, you know, all things to kind of think about and ask patients about. And I think, you know, as far as what you were talking about, like making sure, like, are they, you know, taking NSAIDs, like what are diet changes? So like pathophysiology of GERD, why do we see this? So most of it is this lower esophageal sphincter dysfunction, and that can be from a lot of different things. So dietary stuff, caffeine, alcohol, chocolate's actually a big one I talk to people about. Peppermint's another one people don't tend to know. Smoking, obviously want to, you know, talk to people about smoking cessation, and fats, and then medications as well, which I don't think we think about as much, but they can definitely kind of relax that sphincter. Other reasons, a lot of people have a hiatal hernia. Some people have esophageal dysmotility, which is, you know, when the esophagus does not function the way that it should. And that's a whole other topic that we won't really get too far into. Delayed gastric emptying. So you've all heard of gastroparesis, but this can also be medication induced. And then obesity as well as pregnancy, just because of that increased abdominal pressure. So, you know, in her case, obviously she has had this weight gain. She doesn't really mention any big diet changes. You know, as far as we also want to think about red flags, right? So this is always something we're always thinking about. So what are the red flags for GERD? So these are the people that you want to send directly to GI to have an upper endoscopy when they have, you know, GERD symptoms. So obviously if they're being treated for a different malignancy, it does put it at a little bit higher risk if this is a new onset, you know, reflux symptoms. They also recommend anybody over the age of 60 that has a new onset of these, so they never had it before. Dysphagia is somebody I always send. So that's kind of feeling like food's getting stuck in your throat. And I do try to ask people, is it liquids? Is it solids? Is it both? Do you notice it? You know, a lot of people notice it with bread, with chicken, those kind of drier things. If they have any weight loss, if they have any blood or black stools, iron deficiency, family history of upper GI malignancy. So some people have, you know, what's called GIST tumors, which are gastric tumors. The other thing would be persistent vomiting. So I used to have people come to me and like, you know, I go to bed and like every night I wake up and I vomit like 3 times, or, you know, those are things that's probably pretty severe esophagitis. So in her case, and kind of like what I talk to most of my people who have GERD about, we want to think about doing a PPI trial, because Tums has not been helping. So most likely this is from her weight gain, and kind of probably has had some diet changes, you know, just probably eating more than things. So I usually try to get people to try it for 6 to 8 weeks. A lot of the times it's less than that. Some people only need 2 to 4 weeks. You know, in the literature, they do say that PPIs take 8 full weeks to kind of really be effective for things, but I do find a lot of people feel better after a few weeks, and that's okay. So I talk a lot about lifestyle stuff, because a lot of these people can honestly, you know, some of them don't need a PPI, and some of them will opt for, like, let's just try lifestyle stuff first. So avoidance of trigger foods, so those things we talked about, smaller, more frequent meals throughout the day, as opposed to like a huge dinner and a huge lunch and then not anything in between. I try to get people to eat dinner a little bit earlier, so not eating within 2 to 3 hours of bedtime or laying down. So if you're eating dinner and laying right down on the couch, elevating the head of the bed, and it's about, like, I think they recommend 6 inches, and in the guidelines, it's actually recommended to raise the actual bed, not just on pillows. Not really sure what the research, you know, if they've looked at just pillows, but and obviously weight loss, in this case, smoking cessation. as far as PPIs go, the biggest thing that I used to see is timing. So making sure you're educating people on when to take them. So I always tell people, take it 30 minutes before a meal. If we're doing once a day, 30 minutes before you eat or drink anything in the morning. And if you're going to take it twice a day, 30 minutes, before dinner time. And that just helps kind of reduce that acid a little bit before it gets released when you're eating. It is reasonable too. So if someone's not responding to a PPI to change it one time, there's not a whole lot of research about like continuing to change it 4 times and trying different ones. That's kind of a waste of your time and their time. So as far as what I would say with reflux, kind of like going through that stuff, you can have them come back in 6 to 8 weeks. If you trust them to kind of let you know if they're not feeling better, we can always kind of taper down off them. But if they continue to be unresponsive and they're still having these symptoms or things are not getting better at all, just kind of a thought in your head, like maybe this person needs to go see GI and have an upper endoscopy. So I would just refer them. Some further steps to kind of be aware about, but that not anything that you're ever going to order, reflux and pH monitoring. So these are the people that are unresponsive to a PPI, or they've had an EGD and there's no clear reflux, but they're still having a lot of symptoms. So we're trying to figure out, is this acidic reflux? Is this not acidic reflux? What's going on? Esophageal manometry is actually testing for how well the esophagus is working. So that can look for achalasia, which is basically that reduced motility, and other types of motility disorders. And then the last one would be a referral for Nissen fundoplication. There's some other surgery too, but this is what's considered like the anti-reflux surgery. Not anything that's done around here. I would say mostly Boston. I'm not sure if I think Portland may do it as well. But this is for people who really just have, they have to go through all of this testing beforehand before they'll do this stuff. But it can be really helpful for people who just have severe GERD and like nothing's helping. So just kind of to touch on Barrett's esophagus. So this is, precancerous condition that can happen with GERD that's been untreated for a long time. These people should be following with GI because they need an upper endoscopy every 3 to 5 years. Kind of just depends how severe it is. Risks and who to screen. So this is kind of separate from the GERD stuff, but if you have a man with symptoms, it should be greater than 5 years. Sorry, guys. GERD symptoms greater than 5 years and or frequent. So they have symptoms more than weekly. And they have 2 below risk factors. So obviously like this stuff you're not going to memorize this, but if it's somebody who, they've had GERD for a long time, they're over 50, they're obese, like those are people that you probably want to have, an upper endoscopy. Smoking puts them at higher risk. Being Caucasian puts them at higher risk. And if they have a first degree relative with Barrett's esophagus as well, they're actually I was trying to look at men versus women. There's no recommendation for women for this. So I think it's just kind of like use your best judgment. If it's someone who's had chronic reflux, I think it's just lower risk for women, but it is something you want to think about. So
Sarah, I have a question on that.
Yeah.
Is there, when we're like discussing like education stuff with a patient with reflux and GERD symptoms, is there like a number sort of in your head that you're like, the goal is to avoid more than like 2, 3, 4, like sort of reflux events a month or something that really makes it a more concerning, that would like, make you more concerned for Barrett's and stuff? Like it's hard to say like a number, but should I say to a patient, like, a goal for reflux control?
Yeah. I mean, I think if they're having like, even if they're having twice a week symptoms, like that's a significant amount, right? I mean, it's not like, if it's like once a month or like, they're like, oh, I know, like I eat spicy food and I get it, like, I'm like, yeah, that is probably dietary and just work on that. But if they're like, I have it twice a week, I try to like kind of dig into it like a little bit. Are you having dysphagia? Because some of these people are like, oh, I've had that forever, So kind of like asking them about those red flags and do you have any family history or your things. So I think if they're having weekly symptoms, I kind of dig a little bit. I don't think there's like a clear guideline on that. Like you have to, send, but it is those are the people I talk to about, like, if you're having this much reflux, like you are higher risk for Barrett's esophagus over time. So we should think about, better managing that, whether it's dietary or, trying something.
Yeah, my goal is actually 0. I think they should be having 0 episodes of reflux per month. Again, if it's, provoked, if you
right.
will, I think that's a different thing. The other question I had, Sarah, is I will put people up to BID PPIs, but we all know that they allegedly cause dementia and pneumonia and fractures. So I tend not to do that for more than a month. And if I have to keep them up BID, I send them to GI. Are you going to talk about that, or?
Yeah, my next slide is actually risks of kind of chronic PPI. So yeah, there's I actually just went that Harvard conference I went to, he kind of talked about this too, but there's no proven studies that this causes dementia. There are definitely, side effects to it. So it is stuff I talk to people about. So GI, microscopic colitis, is something that I used to see fairly decent. Fortunately we were causing it, but also seeing it. And then C. diff, you're a little bit higher risk, and then malabsorption. So magnesium, calcium, B12, iron, which obviously leads to, like you said, bone thinning and those kind of things. And then also kind of chronic kidney disease, as well as interstitial nephritis. So yeah, I think as far as, I have my next slide's kind of about tapering and stuff, but I think it's one of those things where if someone's in a flare up, I will put them up to twice daily, but I don't like to do it for a long time either. I like to, if I can do it for 4 weeks or 6 weeks and then kind of say like, okay, let's get you back down. If they need to stay there to be controlled, then they probably should go CGI to take a better look, because they could have esophagitis. So I agree with that. And those are the people too. So if someone comes into you like for their annual, like I just like, okay, how's your reflux? Really good. Okay. You're on a PPI at 40 milligrams. You're on omeprazole 40 milligrams. So, I try to talk to them about like, maybe we should try tapering down. It's not the safest medicine to be on forever, if we can taper you down. So this is kind of a good tapering. And this isn't perfect, right? Like you can change this a little bit as far as how many weeks people do. But so if they're on twice daily PPI, obviously you want to get them down to once daily PPI if you can. After that, you can go to every other day. So, or even if they're on 40, you can cut back to 20. And then once they're on 20, try doing every other day. And the recommendation is actually to do an H2 blocker. So something like famotidine Pepcid on the off day. To kind of help cover those symptoms in between. Do that for a few weeks, and then you kind of keep slowly doing it, take the PPI every 3 days with that famotidine on the off days, and then eventually get to the point where you're just taking the famotidine twice a day. Once you're on the famotidine twice a day, start with once a day at bedtime, and then go to as needed. So this is a long process. It's not like it's going to happen in a week or so. And I try to talk to people about, like if you're feeling really good, we could do it a little bit quicker than 4 weeks, and if at any point you're having a lot of symptoms, you just go back to the stuff that you were on before, and do that for a little bit longer. And that may be someone who like, okay, I'm having a lot of symptoms, I can't get down. Let's just keep you there for a while and like readdress this next time we talk. So I think it's very individualized, but it is something I try to get people off PPIs to at least famotidine if we can, because it is definitely a little bit safer long term. Is that kind of what you do, Jeff?
My taper is even slower. I usually do whole pill, half pill, whole pill, half pill, and do it over a matter of a few months. But you're right. I definitely do try to taper them off.
Yeah. I think you can kind of work with people with how they're feeling. So And some people are like, I did it and I will never do it again. And so just kind of work with those people. And that may be someone you send to GI if it's been a chronic thing. But
for those of us that are gravitationally gifted, I think it is hard to get off completely. So,
yeah, definitely. Yeah. I mean, I had people on it forever. Right. And if they have Barrett's esophagus or they have these, high grade esophagitis, then those aren't people you want to be taking off of them, but they should be following with GI. So, but I wouldn't touch those people if they're well controlled. So kind of, similar peptic ulcer disease, tend to see upper abdominal pain. Depending on where the ulcer is, you'll see it worse with food, which tends to be gastric versus fasting, duodenal. People tend to have nausea, bloating, fullness. Most common causes of this tend to be H. pylori and NSAIDs. So that's why you want to always ask about NSAIDs, because we do see this a lot in people who are like, I just had a knee replacement and I'm having some of these symptoms. So same kind of thing. I mean, when to refer them. So alarm symptoms, a lot of the time, and, with peptic ulcer disease, you're going to see people that are like, I had really dark stools, and sometimes dysphagia, really bad pain, and if they're having really bad pain with swallowing, you should also refer them. That should also be greater than 60 years old. I'm sorry about that. And then, so they don't recommend people who are less than 60 or without red flags to be referred. I think if those people are really uncomfortable, I mean, I would just refer them anyways. But if you're not going to refer them and you feel comfortable with having them in the office, I do recommend doing H. pylori testing because it is one of the most common, causes of this. You can do either breath or stool testing. They both have a greater than 95% sensitivity. I tend to do a lot of stool testing because it's much quicker for me to be just go do a stool test. And then once that's done, once you drop it off, we can start you on a PPI. They both, you should not be using a PPI 2 weeks prior to doing any of this testing. So that's why I tend to say, do the stool test, start the PPI. And you can't have had any antibiotics or bismuth, which is Pepto, for 4 weeks prior. So treatment for this, this is kind of like uncomplicated. You'd see in the office, you're going to start them on PPI once daily for about 8 weeks. I would say most of these people end up on it for longer than 8 weeks. And if it is complicated, which just depends on how big the ulcer is, so that would be something that they would see on endoscopy. They would do twice daily for a longer period. If they do test positive for H. pylori, you want to think about quadruple therapy, which is first line. It's greater than 90% effective. So that's a PPI twice a day. And that actually extends a little bit longer than the rest of the medication. So just make sure you're looking at that. Pepto 4 times a day, tetracycline 4 times a day, and metronide is all 4 times a day. And then the big thing that I often did not see people do was retesting. So you want to make sure that you're retesting, and you can test with either one of those, breath tests or stool tests, after at least 4 weeks have gone by from completion of therapy. The reason is that sometimes it doesn't, right? There's that 10% of people who still have it, and then their symptoms are just going to continue.
Sarah, I have a just clarifying question.
Yeah.
Do you do the PPI for 8 weeks before you start treatment, or are those concurrent with the antibiotics? And
so the PPI once daily for 8 weeks would be like someone who just like you're treating in the office, they're negative for H. pylori. If they're H. pylori positive, then you want to do the PPI twice a day. I think it's for 8 weeks as well, but the antibiotics are only for 2 weeks. So you want to finish those antibiotics and then continue the PPI for that extended time. That makes sense?
yes, sorry, it does.
Okay. Yeah, and I know, Jeff, you said no rule for blood testing for H. pylori. Yeah, I don't recommend that either. Awesome. Anyone have any questions about that stuff? We're going to kind of go into something different.
I guess I just had a quick question. If someone's having some pretty atypical GERD symptoms, would you just kind of include this in your differential and do the H. pylori testing because it may be pain related to an ulcer and their GERD?
Yeah, like if someone was having like pain, is that what you mean?
Yeah, yep.
Yeah. I mean, I tend to like, even if, like if someone comes in and they have like nausea, nausea is one of the biggest concerns for gastritis, which can also be due to H. pylori. So nausea, bloating, abdominal pain. So like kind of those, yeah, not clear cut heartburn. I would say like testing for H. pylori is not a bad idea, because it's so easy to do.
Thank you.
Yeah, of course. All right. Keep going so you can get through this stuff. So the next one, diverticulitis. So 88% of patients have uncomplicated episodes and can be treated as an outpatient. This means no abscess, fistula, obstruction, bleeding, or perforation. So just kind of something to think about. But 42-year-old male presents to your office with left lower quadrant pain for the past few days. He's afebrile, appears non-toxic, abdominal pain with mild left lower quadrant tenderness, no guarding or rigidity. Only past medical history is hypertension and obesity. He has a history of diverticulitis. This is how it felt last time. Do you send him to the ER? Do you treat him in the office? What are your next steps? Want to have any thoughts?
Bowel rest, not antibiotics.
Anyone else?
I don't think he needs to go to the ER. And I feel like every time we talk about this in different classes, we're told something different as far as antibiotics. So I feel like you're going to tell us to give him antibiotics from the office, but I also think we've been told that that's kind of going away and just we do bowel rest.
Yeah. So, you know, in this case for this person, right, they have a history of diverticulitis. It's really similar to what they felt before. What I tend to do for these people is I will have them, like, especially if they're in my office, I'll have them go get their labs done that day. So like I'll have them do a CBC and a CMP just to kind of make sure their white count's not 20 or something insane. You know, and then what I would do is I would think about antibiotics. I would talk to them about it, and I'll kind of go through kind of like the recommendation, the guidelines. If this was his first episode, like say like he didn't have a history of diverticulitis, he doesn't really know what this is. I would think about sending him to the hospital to get a CAT scan, or trying to get a CAT scan as soon as we can. You know, it's always hard because you don't want to send these people to the ER if you don't have to, but it is something that sometimes happens. So I'm just going to go through some of the kind of practice updates from the AGA. So CT should be considered to confirm diagnosis of diverticulitis in patients without prior imaging confirmed, and to evaluate for potential complications in people with severe presentation. Also, for people who fail to improve, are immunocompromised, multiple recurrences, and are contemplating surgery. And the reason for that, the recurrences, is that we want to, you know, if they're thinking about surgery, we want to make sure it's in the same place. So, you know, if they're having these episodes in the same exact place, that's going to tell us that surgery can be helpful. So in his case, right, I mean, we don't necessarily have to do a CAT scan for him. He's already had it confirmed before. I would make sure you have that CAT scan. If you don't have a CAT scan, sometimes a little bit, you know, wishy-washy about what to do.
Sarah, just sorry, quick question there. So are we looking for a prior diverticulitis confirmation, or if he had a colonoscopy that confirmed diverticulosis, can we use that as a presumptive diagnosis as well?
Yeah, I mean, I like to see that they've had a CAT scan to confirm that they have diverticulitis. But if they don't, and they had a colonoscopy saying diverticulosis, I mean, it makes it much more likely, right? But if he's never had a CAT scan, then I would think about doing a CAT scan that first time. So we'll start with kind of this bottom one, this best practice advice 5. So clear liquid diet advised during acute phase of uncomplicated diverticulitis, and then diet should slowly advance, which is, I know what you guys have all already been taught and learned. The other thing that I find a lot of people were not kind of aware of is that patients should have a colonoscopy after an acute episode of diverticulitis. If it's their first episode, or, you know, they haven't had a colonoscopy for a long time. So if somebody has a first episode of diverticulitis, you do want to refer that person to GI. The reason is that there is a potential that malignancy can be misdiagnosed as diverticulitis. It's not very common, but it can happen. And if you're going to refer those people, they tend to delay the colonoscopy by 6 to 8 weeks or until they're feeling better because the inflammation. And then obviously this is one we talked about, right? Antibiotic treatment can be used selectively rather than routinely in immunocompetent patients with mild uncomplicated diverticulitis. Antibiotics advised in those who have comorbidities, which I would say is a lot of our patients, or are frail, who present with refractory symptoms or vomiting, have a CRP over 140 or baseline white blood cell count over 15. Obviously, if they have complicated diverticulitis, like if they have a fever, they're really unwell, they should go to the hospital and get a CAT scan anyways. So I have to say that like in GI, I would say most patients are still getting antibiotics. I know me and Jeff just talked about this. He had a patient that did not get them in the ER, but we've talked about it, right? If they're coming into your office, they're in that much pain, I tend to do antibiotics. Most of my patients have comorbidities, right? Like these are not like, they don't tend to be 30-year-old healthy women who have no other issues. They tend to have high blood pressure, obesity, diabetes, things like that. Occasionally you do get people who do not have those. And I think that would be reasonable to think about, waiting. If you're going to choose not to do antibiotics for these people, I do think you need to follow them really closely. So, checking in with them in two or 3 days just to say, hey, are you better? And giving them a really strict kind of return precaution. Like if things are not improving or things are getting worse, fevers, you need to go to the hospital, that kind of thing. If you are going to treat them, there's 2 options now. Augmentin tends to be the easier one that I go with. That's 10 to 14 days. And the Cipro and Flagyl is also 10 to 14 days, but that one's obviously have to take 2 medications and 3 times a day. A repeat CAT scan is not needed unless the patient is not improving or worsening. And the other thing I kind of wanted to touch base on is like when to refer to surgery. I know it used to be like, they have 5 episodes in a year and you should refer them. They should have surgery. They're really not basing it off on a number of episodes anymore. It's really more, is it in the same spot for patients? Are they really bothered by it? Do they want surgery? So they kind of put it as more of individualized. And so those patients who come to you and say that, I usually, have them talk with a surgeon, and that's fine to do. So yeah, anyone have questions?
So
that helps.
Comment on the antibiotics. 2 years ago, to my knowledge, and maybe the recommendation was there, but nobody had heard about it. 2 years ago, everybody did antibiotics. And this is a relatively new thing to try to go without antibiotics. And so I think you need to very much think about what's the usual and customary practice in your area. And if the usual and customary practice is to do antibiotics, if you choose not to do antibiotics, be very aware that people are going to look askance at you. Because I've had a number of people who, even when treated with diverticulitis, have ended up with abscess formation. And if you haven't treated them, somebody's going to go back and question it. And because it's such a new recommendation, you see these recommendations, and then 5 years later, somebody's like, well, you know what, that really wasn't that good of a recommendation. Let's go back to what we were doing before. So, as I say, buyer beware, I guess, is the only thing I would say.
Yeah, I have to say, I tend to do it. I think if someone's sick enough to be in your office, then it's probably worth it to do. I mean, if they're like I just, it's getting better and like I just wanted to come in and check it out, like I'm feeling really good, then I'll be like, okay, let's check in again in a few days. But if they're like, this pain is not getting better, I just, I have some diarrhea, I treat them. So yeah, I hope that helps clear up some of the confusion. I know it's still very like Jeff said, new, and I think a lot of people are kind of doing what they've always done, and it's a big change. So good. Okay. So let's go on to rectal bleeding. So rectal bleeding, also just as a heads up, if someone says they're having left lower quadrant pain with rectal bleeding, that is not diverticulitis. I mean, you should be concerned that there's something else going on, whether it could be a diverticular bleed, but those people should not be treated kind of outpatient. Just keep your, red flag ears up. So when someone comes in with rectal bleeding, which is very common in primary care, like 2 weeks ago, I had some blood on the toilet paper. That's very common to hear. I try to, quantify that for people. Like, is that a few drops? Is it a gush of blood? Is it clots? Is it on the toilet paper? Is it in the toilet bowl? Is it in the stool? And try to get a better idea. If it's just when they're wiping on the toilet paper, more likely that's kind of a local benign anorectal disease, versus if it's in the stool, that's a little bit more concerning. The hard part about blood is even a drop of blood in the toilet bowl makes the whole toilet bowl look like, a murder scene. So it's scary for people. So things that you want to kind of look, ask about associated symptoms to suggest, severe GI bleed, which most of those people are not going to be in your office, right? Like they're, feel like they're going to pass out, the short of breath, any fevers, signs of inflammatory bowel disease. So all those things we talked about. And are they having rectal pain, right? So like if they're having rectal pain, they're straining, they're constipated, more likely to be kind of a, more benign anorectal disease. However, you can have internal hemorrhoids that have some painless bleeding, which is kind of what we talked about, that little bit of, when you're wiping. So the differential for rectal bleeding is really big, right? So hemorrhoids, anal fissure, diverticular bleed, GI bleed, inflammatory bowel disease, abscess, malignancy. So these are kind of the things to evaluate that I do, a CBC to rule out iron deficiency anemia, doing a rectal exam, making sure that, do you see a hemorrhoid? Do you see a tag? Anything like that? Do you see a fissure? Actually making sure there's no mass or anything in there. Make sure their colorectal screening's up to date. You can consider Hemocult cards, send them home with. And then most of the GI docs will do a flexible sigmoidoscopy, which is basically, just looking at the sigmoid colon. Some of them can do that in the office, if this is an ongoing thing. So I would say if, they've noticed this for a long time, sometimes it's worth it just to have them, go CGI and make sure there isn't anything else going on. Don't want to miss those big things. Hemorrhoids, like I said, internal hemorrhoids can cause bleeding for people. Sorry, guys. So things I talk to them about: avoid prolonged time sitting on the toilet. The other, if you guys heard of those like potty chairs where you can kind of put your feet up a little bit, it actually helps relax the pelvic floor for people, increasing fiber, hydration, treating constipation, like we talked about, Miralax, things like that. I will say, I know me and Jeff have talked about this before, but Colace, which is stool softeners, there's no evidence that they're helpful at all. I actually I'll occasionally use them for people if they really don't want to do anything else, because sometimes it's a little bit helpful, but most of the time it's not. And then thrombosed hemorrhoids are something that I see fairly frequently. They're very painful for people. It looks kind of like a bulge kind of at the rectal area that's a little bit bluish in color. Sometimes they will rupture on their own, and that's when people notice that big bleeding episode, and then they say it stops. Often resolves on its own, but sometimes you can drain and kind of remove that clot for them if it's really painful. So. Just a quick touch on hemorrhoid treatment. So there's two big ones you can do. Banding is for the internal hemorrhoids that GI will do, but proctology will also do. They basically put a band around that hemorrhoid and it cuts off the blood supply and it falls off. There is a risk of, bleeding from that, but it's pretty mild. And then also having the hemorrhoids actually removed with the surgeon, it's a pretty in-depth procedure. So it's not something that a lot of people like to go through. It's a long recovery time. So just so you're not, referring everybody who has hemorrhoids over to them. So, and just briefly to touch on iron deficiency, the one thing I would see in GI is that people were not confirming that the anemia was iron deficiency. So they would just send over someone has a hemoglobin, of 9.5, but they have a normocytic MCV. So like, what is it? Is it B12? Is it iron? So making sure you're checking ferritin and iron TIBC when people are anemic. Younger women who are menstruating and they have heavy menstruating, they probably don't need a GI workup right away. It's reasonable to kind of, try to get that under control, see if it improves. Obviously, if they have any GI symptoms, then you refer them. But if they don't, and it's just heavy, I would say start with that. GI tends to like to do Hemocolt cards for these people, start them on an iron supplement, and then refer them to GI if they're not, don't have heavy menstruation. So that was just kind of my quick spiel about that stuff. Do we have questions?
Proctology will also do infrared for hemorrhoids. Mixed benefit, but some people get great benefit from it. I am very cautious about starting anybody on iron for iron deficiency anemia until I'm convinced that they don't have a colon cancer. For me, rectal bleeding is colon cancer until proven otherwise.
Yeah, that makes sense. I think, but if you're going to send them to GI and they're going to have that workup anyways.
Yeah.
Right.
Yeah, agree.
I think as long as you know that the patient's going to go and, but you can leave it up to GI if that makes you feel uncomfortable too. Just sometimes it can be a while till they get there. So we'll just run through this case kind of quickly. And then I want to kind of talk about like liver, gallbladder, that kind of stuff. Make sure we get to some of that. So Jane comes in to see you and states she no longer wants to see GI. She's had a CT, an EGD, a colonoscopy, too many lab tests. They've not given her a clear diagnosis. She does not feel like they're helping her. Continues to have mild generalized abdominal pain, does not meet criteria for other GI issues. What do you think you would, talk to her about? To someone who's kind of like functional abdominal pain, has kind of had the full workup. And we kind of briefly talked about this, but.
I find these patients really tricky because I don't know what to do with them often. But would it be worth like some ultrasound to go like the GI-GU route or?
Yeah, I mean, it's definitely something to think about, right? Like in these people, like, she is a female, like, did you look at pelvic? You always want to kind of think about that kind of stuff in women. So if they haven't looked at that, but she had a CAT scan, if they looked at her pelvis or ovaries looked okay, that kind of stuff, not overly concerning, but you could think about having her see gynecology. So I think these are the people we talked about, like with IBS too, right? So, listen to like what they've gone through, be understanding. And then I tend to talk to them about, like we talked about this, neuromodulators, like starting them on something like amitriptyline or Cymbalta at bedtime, not blaming it on mental health, but just kind of like bringing that up, like, have things been going on? This may be your body's way of saying you're a little bit, stressed out. And I tend to find these work really well for people. I've had people we've tried everything, right? Like PPIs, IBGAR, like we've tried everything you can think of and it doesn't help. And then we put them on some amitriptyline and they're like, I feel a little bit better, and that gives them a little bit of hope. So, I just wanted to kind of throw that in there, something to think about. I know we already talked about it, but okay, we're gonna switch it up to kind of gallbladder stuff, because I feel like this stuff was really confusing to me as like a new nurse practitioner. Like gallbladder and like what is cholecystitis versus cholelithiasis versus cholangitis, right? They're all just like big words that are confusing. So cholelithiasis is stones, right? So stones in the gallbladder. Often we find them incidentally. Sometimes we are looking for them. So someone has kind of like intermittent right upper quadrant pain. We do the ultrasound, we see this. Those patients, I talk to them about, if they're symptomatic, I'll send them to the surgeon. If they're not symptomatic and we just kind of found it, some of those people want to see the surgeon and have their gallbladder out, and some of them just kind of want to keep an eye on things. And so I just individualize that. Actual cholecystitis, which is inflammation of the gallbladder, tends to be that right upper quadrant pain, can radiate to the back or the right shoulder. Tends to be exacerbated by food intake, particularly fats, typically lasts 30 minutes to an hour and then plateaus and kind of subsides. So this is not something where someone has chronic abdominal pain tends to not be from the gallbladder. Acute episode, these people typically end up in the ER, right? They have fever, they have nausea, they have vomiting, they really don't feel good. Outpatient, if this happens, I tend to do a right upper quadrant ultrasound just to kind of better evaluate. And I know Jeff brought up too, kind of with GERD symptoms, sometimes that epigastric pain, like I will often do an ultrasound for that too, just to rule out that it's not the gallbladder. If that's negative, you can also think about a HIDA scan, which I'm sure you guys have heard about. But what that checks for is how efficient the gallbladder is working. You always want to do it with an ejection fraction. If you don't do that, it's not very helpful to you. That's kind of, like there's no stones, but it does sound really gallbladder-like. So you want to think about doing the HIDA scan. And if you don't feel comfortable with that, you can always send them to GI as well, and they can kind of do that. So this is kind of a good explanation of what those words mean. So, like we talked about, cholelithiasis is the gallstones. Cholecystitis is when those gallstones kind of get stuck in here and cause inflammation. Cholelithiasis is actually when a stone gets stuck in this main duct here. And then cholangitis, it is actually more of an infection associated with the obstruction. So those people are pretty sick. So when they have cholangitis, they have a fever, they have jaundice, they have right upper quadrant pain, white cells elevated, LFTs are elevated in a cholestatic pattern. Those people need to be in the hospital. As far as the common bile duct stone, which is the cholelithiasis, these people also tend to have similar symptoms, but they don't have the fever. Not all of them have jaundice, but some of them do, and the bilirubin can be high. Those people are people who need to see GI as well for what's called an ERCP. And so what that is basically they go into those ducts themselves and they can retrieve those stones. They can put stents in if they need to. So, and then we talk about a little bit of pancreatitis, which can also be related to gallstones. So most common etiologies are alcohol, gallstones, hypertriglyceridemia, and also something I wasn't super aware of till I worked there is like after an ERCP, it can actually inflame the pancreas as well. So they do try to keep an eye on those people. So most of these people do end up in the ER just because they're in pretty severe pain. Treatment for this tends to be just fluids and pain control. There's not a whole lot that you're going to do. But evaluating for someone who you think may have pancreatitis, looking at amylase and lipase, the amylase rises a little bit later and then returns normal pretty quick. And then lipase rises quicker and lasts for a longer time. And someone I'm really worried about their pancreas, I check both. A lot of people just do lipase and that's fine. But if you're worried about kind of an acute onset, the amylase will be up too. And the CMP to look at the liver. Oftentimes in the hospital, they'll just do a CAT scan. I usually recommend doing an ultrasound outpatient if they haven't, to look for those gallstones and see if they need to, have a surgery referral. If their pain's persistent and it's like similar to their pancreatitis, I usually would say send them to GI. They can do what's called an EUS, which is an endoscopic ultrasound to actually look at the pancreas itself, and also look for further lab stuff. You can have autoimmune pancreatitis and other things. Quick thing on pancreatic cancer, just because obviously we all know it's really something not good to have. Lifetime risk is low, 1.7%. However, 52% of people diagnosed have metastatic cancer by the time they're diagnosed. At 5-year survival rate is only about 3%. So it's pretty low. Symptoms are often really vague. So that's the hard part about diagnosing this. Weight loss, poor appetite, bloating, painless jaundice is something you always want to look at. I'm sure you guys have heard that a million times, but definitely a big red flag. Complain of light colored stools, dark colored urine, new onset diabetes in someone you just didn't really expect it to happen, some upper abdominal pain. So evaluating this, typical lab work, INR to look at the liver, lipase, amylase. CA19-9 is actually a cancer marker that's GI kind of specific. So I usually recommend that. If that's elevated, that's more concerning. I tend to do a CT on these people. You can do an ultrasound. However, I often find that they say couldn't evaluate the pancreas due to overlying gas. So that gets a little frustrating. So I tend to go for a CT when I'm really concerned about these people. As a PCP, kind of what do you do next for these people? Referral to GI so they can visualize the area and do a biopsy. So ERCP and EUS, like we talked about for pancreatitis and gallbladder stuff, and then referral to a cancer center. However, most of them want to see the biopsy before they'll see the patient. But just so you know where to go next with that stuff. Okay, I'm gonna go into some more liver stuff. 37-year-old male presents with elevated liver function tests. BMI is 32, his blood pressure is 126/80, heart rate of 84, ALT is 58, AST 49, Billy 0.6, ALK Phos 130. Looking back, his LFTs have been very mildly elevated for a few years. It's actually a patient that I saw recently that I just took over as PCP. Alcohol is rarely 1 to 2 drinks on the weekend, no drug use, no recent travel, medication, diet changes. He's asymptomatic. He's here for a wellness visit. What do you think you would do next? Is this, cholestatic? Is this hepatic liver? Any thoughts on what you would do?
I guess I was thinking of like one thing could be with a higher BMI, maybe just some effects on the liver there. And then I don't know if this is someone that we would check if they've had that like one-time screening for hepatitis, or if we would check to see if that's a thing that they've ever had in the past.
Mm-hmm. Good. Okay. Anyone else have thoughts?
Would it be worth doing like an ultrasound of the right upper quadrant to look at the liver and gallbladder? Because the Billy's not super high, but the ALK Phos makes me lean more towards liver, I guess. Yeah, no, you're right. I mean, it's a hepatic pattern. So his ALT and AST are a little bit elevated. They're very mild. So in this case, this has been a few years of this. And so I would look into this further. So for this patient, I'll kind of go through, the question is why, right? So if this was the first time his liver enzymes look fine, this is the first time I'm seeing this, I would probably just say, let's recheck it in a few months, see if it's still elevated. You can see this sometimes with infections like COVID, viral illnesses, and kind of see if it's still up. If it continues to be up, I usually will kind of look into it further. So this is a lab workup for elevated liver function tests. This is something you want to do if they're persistently elevated, or if they're like significantly elevated, like they're in the 300, 500, that kind of range. You want to think about doing this lab workup. So you want to check for hepatitis. So the hepatitis panel, A tends to be more acute, but I usually test it just to see if they are immune to that. B and C, anti-smooth muscle antibody is actually something you're looking for autoimmune hepatitis. Ferritin iron TIBC is you're looking for hemochromatosis, which is iron overload, which can cause long-term liver issues. Celiac testing, thyroid testing, because those can all also cause this as well. Alpha-1 antitrypsin, and then ceruloplasmin is Wilson's disease. And I tend to only check those in younger people under 40.
Sarah, so if you go back, I think it was 2 slides, when you said hepatic pattern, yep, is that meaning low Billy, higher ALK Phos?
So actually just ALT, AST being higher.
Okay. Yeah. And then if the Billy was high, that would lead us to also suspect gallbladder involvement.
Exactly. So if the Billy and the ALK Phos are higher than the ALT, AST, then you're going to be more concerned about a cholestatic. So gallbladder, pancreas, that kind of thing.
Okay.
Yeah. Exactly. And I think I probably have some of those. There's a good guideline with kind of looking at that. I could probably get you guys. So in this case, my first gut is he has fatty liver disease. And so this can be chronic, mild elevation of liver enzymes. Patients tend to be asymptomatic. They tend to have, metabolic syndrome. So they can be obese, high blood pressure, diabetes, that kind of thing. But oftentimes we see this in people who do not have those yet. So often we also find this incidentally on imaging. So they had a CAT scan in the hospital and they say, increased fatty liver, or if we're ordering an ultrasound. So in his case, we want to order a right upper quadrant ultrasound to kind of look at the liver. We want to do this lab testing. Other, etiologies of fatty liver, just to think about, alcohol is a big one. Non-alcoholic fatty liver diseases, those two are kind of the biggest two risk factors for this. Like we talked about, thyroid, Wilson disease, hepatitis, and then some drugs can also do this as well. So non-alcoholic fatty liver disease is most common cause of elevated liver enzymes in the United States. This talks a little bit about how we go from a healthy liver to basically liver cancer. So what happens is over time, with poor diet, exercise, you end up, like we talked about, that metabolic syndrome, fat accumulates in the liver, and what's called steatosis, which is that fat accumulation. And that's like this 25 to 30% of the population. This is a significant amount of people that you're going to be seeing that have this. And then over time, as this gets worse, you start to add inflammation, which we call NASH. And then it continues into fibrosis, which is the scarring that happens to turn into cirrhosis. And then over time, it can develop into liver cancer. It is, I will say, I think a lot of people think about alcohol and liver cancer being a big risk, but this is also a really big risk for liver cancer. I used to see this actually quite frequently, people who've had non-alcoholic fatty liver disease that just don't control these things and eventually end up with cirrhosis. So it is something to really, be mindful about.
And can I just ask a question?
Yeah.
That is caused by, that's just a lifestyle thing. That's a diet and exercise.
It can. Yeah. There's also, let me show you these are all the etiologies of fatty liver. So alcohol can, non-alcoholics are those lifestyle things, but also this is why we want to check some of this other stuff, make sure their thyroid is okay, make sure we're ruling out those other things. And obviously if they're on any of these kind of, harder medications as well. So
okay.
Something to think about though, because like some people we have on minocycline for acne, right? So, if they have fatty liver and no other risk factors, it might be worth it to look at. So,
Sarah, what's our role in assessing the progression of this? Like, a lot of times we do annual blood work and things like that, and maybe we would see increasing bump in LFTs or something, but should we be doing imaging or,
so these are the people that I want you to be doing those lab work on. So if this is a persistent elevation in their liver enzymes, I want you to do that ultrasound and I want you to do the labs. And then I'm going to show you kind of what you can do in primary care to monitor this. And it will be helpful for you to say, I can monitor them here, or I need to have them see GI. But first kind of steps for you are going to be, if you see this persistent mild elevation, is you're going to do those labs and you're going to do the ultrasound. And then I'm going to talk this what's called this FIB-4 score. Has anyone heard of this before? Okay. Yeah. I figured not. It's not something I really knew much about, until working in GI, but it's something that I recommend you guys all do. So the FIB-4 score is actually a score that a GI doctor kind of made up to try to help tell us the risk of fibrosis. So is this regular, just like a little bit of fat in the liver, or does this look like this could be severe fibrosis and lead to cirrhosis? So this accounts for their age, AST, ALT, and their platelets. So these are things you want to be checking. I would say checking at least yearly for these people, like checking a CBC and a CMP to kind of get this and calculating that FIB-4 score. I'm going to show you, I'll show you kind of a, for him. So for him, I did the ultrasound, showed mild hepatomegaly, so increased size of the liver with increased echogenicity consistent with fatty infiltration. And then this is his FIB-4 score. So this is on MD Calc, which I don't know if you guys have used before, but you can pull up the FIB-4 score right on there. It's super easy. So you put in their age, you put in those numbers, and then it's going to spit this score out. So it spits out a score of 1.08, advanced fibrosis excluded. So for this patient, he does not need to be referred as long as his labs looked okay. So if he didn't have, like, we're not concerned about hemochromatosis or his autoimmune marker was okay, then we're going to, keep him in primary care and just kind of recheck this. I'm going to show you kind of what would look like for me to refer someone. So this is the same guy. He's 37. His liver enzymes are a little bit higher, 72, 78, and his platelet count has gone down. And so the platelet count is actually a really good indicator of liver function. So for him, it shot up to 1.59. Further investigation needed, approximate fibrosis 2 to 3. So in that case, I want him to go see GI. And the reason is I want him to get what's called a FibroScan. It's an ultrasound that looks at the liver and tells us how much scarring and how much fibrosis is there. And from there, they can kind of monitor that patient going forward for, progression to cirrhosis. The scoring is from 0 to 4. So for people on like 0 to 1, those are the people that it's going to say advanced fibrosis excluded. For people who are 2 to 4, they're going to say you should have further investigation done. So, in his case, they're pretty mild. It's been like that for a while. He has fatty liver disease. We're going to talk to him about, all these things. Let's talk about weight loss is basically the mainstay of fatty liver disease treatment. So 10% weight loss over 6 to 12 months. Obviously not everybody's going to do that, but even if you can encourage some, weight loss for them, if they're diabetic, you want to think about a GLP-1. They also mentioned pioglitazone. To be honest, I don't see very many people using that anymore. So I would think about a GLP-1. Vitamin E is actually for people who have NASH. So this isn't something that I would recommend you just give to people. I would leave that to GI as well. And then I want you to make sure you're treating hyperlipidemia with statins. I feel like it's a big thing, right? Like people are like, their liver enzymes are high, I'm not going to put them on a statin. These people benefit extremely from statins, except in people who have cirrhosis and they're decompensated. You don't want to start that. And then you want to limit alcohol. The other, I don't know if you guys have heard of any of the studies, but coffee has actually been proven to be really helpful for liver disease. So that actually a lot of the GIs encourage people to drink coffee, obviously not with a bunch of cream and sugar, and there haven't been really good studies about like how much coffee to recommend, but they're not telling people to stop drinking coffee for this. Let me go back and just see. Yeah, we talked about that. Okay. And there are just, some limitations to that FIB-4 score. So if they have ascites, which is kind of end stage, when they have cirrhosis, they have heart failure, they're pregnant, those kind of things. This was actually a study on statins and those with elevated LFTs. It was a post hoc, so it wasn't like a controlled trial, but basically showing that overall statins are, relatively safe for people who have mild LFT elevations. I think 880 people were on statins, only 7 discontinued due to LFTs greater than 3, the upper limit of normal. And those on statins actually showed improved LFTs. So I wouldn't be scared to use that stuff unless if they're in the 500s, I would not start it. I'll make sure you guys have these slides, but this is kind of their pathway for this so that it's helpful for you. They actually recommend, and I don't think it's like, Jeff can speak to this too, but I don't think people are actually doing this, but even people who are not seeing elevated liver enzymes, or have, like we saw a fatty liver on an ultrasound or something like that, they're actually recommending people who have risk factors without that stuff be evaluated for fatty liver just because of how prevalent it is. So if they have 2 or more metabolic risk factors, those people who have obesity and diabetes, or, they're actually recommending we check a FIB-4 score for these people, which I don't think is really being done very often. So like we talked about, CBC liver enzyme test, then doing that non-invasive testing, so the FIB-4 score, and then depending on that, either we kind of repeat or we send to GI to kind of have further management. This kind of talks about what we talked about as far as treatment risk, so I'll make sure you guys have that stuff. And then I wanted to just briefly touch on cirrhosis. So these patients obviously are going to be followed by GI pretty regularly. They are people you want to make sure are following with GI because they do need a lot of maintenance testing. So they have upper endoscopies pretty regularly to test for esophageal varices, and they'll have those banded if they see them. They do regular lab testing for cancer markers of, of liver cancer. There is something also called a MELD score that they'll do based off of their labs, and that actually tells them where they are in the transplant list. So if they're higher, lower scores actually mean they're higher on the transplant list, and then they can refer them to a tertiary center for that. And they're getting tested every 6 months, basically with an ultrasound or a CT or an MRI to test for liver cancer. So these people are really, really high risk for these things. And I think that's all I have. So I don't know if people have questions. I know that was a lot of information.
How often, so if we start someone on a statin that has had persistently elevated enzymes, what monitoring would we want to do around that?
I would probably, for those people, because I know now that with cholesterol, they're saying you don't have to check LFTs after. I tend to check, I'll recheck the lipid panel and LFTs in 2 months, 2 to 3 months. And just see what that looks like. And then if it looks stable, you could check it again. I would say just kind of keep an eye on it. If it looks like it's going up, I would continue to check it kind of on regular intervals, but yeah. Yeah. Okay. Anything to add to that, Jeff?
Just a comment on the pioglitazone. I have probably half a dozen patients on it, just because if you look at the AACE guidelines, if you've got somebody that cost is an issue, you're supposed to start with metformin, then go to a sulfonylurea, and then they actually suggest pio as third line. Pio is black boxed for bladder cancer. So obviously there's concern there. On the other hand, there's actually some recent studies that seem to suggest that it decreases the risk of dementia. So, like I say, it's a controversial medicine at this point. Many people don't use it because of the black box and because all of the other glitazones have actually been taken off the market because of liver issues. And some heart failure issues as well. So you really shouldn't use it in anybody that has active heart failure. But it may have a role, and I wasn't aware that it was actually supposed to be protective for, NASH type things. So that's actually pretty interesting. So it'll be interesting to see if it gets used more, but that's, that was my only thought.
Yeah. And I think the other thing, I don't think the GI doctors are prescribing this stuff. Like they're not going out and saying like, oh, let me put you on pioglitazone or a GLP-1. Like I don't think they're really, getting that into it, which is unfortunate. But so that's why it's something on your radar, if they're being treated for non-alcoholic fatty liver disease, think about what their other risk factors are, comorbidities, and like, how can you help with the weight loss and that kind of thing.
It'll be interesting to see if GLP-1s are covered for that, just because so often, you're trying to prescribe them for weight loss or whatever, and they're getting denied. So it will be interesting to see if you've got a diagnosis of non-alcoholic fatty liver disease, if you could get it covered on the basis of that.
Yeah, that would be interesting, huh? You'll probably get it covered easier for a lot of these people.
Yeah.
That was the case.
Jill, did you hear back from Melody?
I did. So she said that she sent you an email. So basically she fixed the exam today because it was still reading expired for some people. So it's available now through Friday at 9 p.m.
Okay.
Even midnight because I think it's Pacific Standard Time. So it's for everyone to take before Friday night.
Okay, so I'm going to actually just, I have that email. It didn't seem to answer all the questions. So I'll actually just post it as an announcement. And what did she say about the career center?
She never answered me on that question.
Okay.
In her email, she just sent an email out and she sent a link. Well, I guess it might just be, I got the email link. I don't know if that means we should go or shouldn't go, but she did send out a link to that noon meeting with Stacy Stewart, it looks like.
And what time does that start?
I think it's at noon.
Okay. Yeah, I will post that because the link is in that email. So I will post that. I guess that for my group, I guess that means we won't do conference today. So because you can work on your exam, you can go to the career center thing. And then I'll see you all next Tuesday at 8:45. We're going to do on-call cases. And I will, Sarah, do you want me to post your email in case people have questions?
Yeah, it's fine.
Okay.
And you said we'll get these slides?
Yeah, I'll send them to Jeff or something and he can get them to you. And if you guys have questions, I know there's like the liver stuff, there's a lot more stuff I can go into. So if you have like specific questions, just let me know. And I can, if you guys, do you feel like you need more help with like liver function tests?
Yes.
Yeah. Okay. All right. I can try to get you, I think there's a good guideline of kind of like flow sheet with that. That might be helpful.
That would be great. This was really, really helpful. So thank you for taking the time.
Of course.
Thank you, Sarah.
Sarah, how long have you been a nurse practitioner?
I graduated in 2019. So 4 years now. Yeah.
Well, I thought it was a lot longer. You're very well versed and
I appreciate that.
and yeah, and thank you so much for inspiring all of us.
Of course. Yeah. No, gonna do great. You're almost there.
I did tape this too, so I'll probably, with Sarah's permission, I'll actually put it on my YouTube channel,
Sure.
as well as I'll post it on the Blackboard as well. Brightspace, excuse me. So.
Yeah, and if people have questions just about like anything else in general, like just working in GI or primary care, and like I know I've gone through it sooner, feel free to message me. I'm happy to help. So, yeah.
Thank you so much.
Yeah, thanks for